I'm here to talk to you about women's allergy, and see if I can make this work. How do I do? I'm Dr. Honsinger. I've been in Los Alamos for 49 years, and I've had a number of things that I do that I think qualify me to talk about allergy. I have my boards in internal medicine and allergy immunology, and I currently serve on an advisory committee on allergy for the Food and Drug Administration, where we review new drugs to see if they're efficacious and if they're safe. I represent allergy on the Council of Subspecialty Societies, along with cardiology, gastroenterology, neurology, etc. And so I get to talk to a lot of other specialists that way. And I have students come through our practice in Los Alamos. We have medical students, and we have internal medicine and family practice residents that want to learn more about allergy come through Los Alamos. And now that Dr. Snowden is with me, they come through and they get an allergy rheumatology rotation. I've done a lot of clinical research, and part of that's because of Los Alamos. Los Alamos is a community that's very scientifically oriented. They're willing to participate in research projects, and they keep good records. So that's been something that's helped us get clinical research in Los Alamos, and me get publications out of it. We have something called the Joint Council of Allergy, Asthma, and Immunology. This is funded by the two large allergy societies and represents the two large allergy societies and about 56 other allergy societies around the country. And your first question should be what is allergy? And after what is allergy, we should talk about how we diagnose allergy, why do we have allergy, how do we treat allergy, and then allergies, men have allergy as well as women. But there are some special things about women and allergy that I will bring up. And then I'd like to have time for questions at the end. First of all, how common is allergy? Certainly all of you here most likely have allergies, or you have friends or relatives that have allergies. That's because 20-25% of the population has some allergy. And with that frequency of allergy, we spend a lot of money on allergy. It's our most common respiratory disease that people have. And there are millions of office visits to doctors, to ear, nose, throat physicians, and to allergists who want treatment of their allergies. And that's their allergies, maybe hay fever, it may be asthma, it may be hives, the things that we see. The cost of that is $8.9 billion, and that costs the employers a fair amount of that as well when people have to take time off from work because their eyes are swollen, because their nose is running, or because they're wheezing. Definition of allergy is easy. It's when your immune system reacts to something and it harms you instead of helps you. If you're fighting off Ebola virus or you're fighting off tetanus, that's good for you. If you're fighting off the pollen in the air, that often may bother you. And so when we see an adverse response in the immune system, we call that allergy. Now, why do we have allergy? There's several arguments about why the allergy mechanism is like it is and why we're getting more allergy. And I'll talk about one of those a little bit later from a study we did in Los Alamos. But we think that as we clean up our environment, that we're making more antibodies to things in the air instead of things that we fight as far as bacteria and infections. The indoor antigen exposure, if you have less allergy if you have a cow right outside your bedroom. And so societies that have the animals in the house with them and turn out not to have as many allergies. And we'll get to that in a minute. We know that we've always thought that dust mites cause allergy. A little bug that lives in your dust, and as you clean your house and and vacuum your heating system and try to get rid of the dust mites, you may have less allergy. And so, but these things actually make you turn more to an allergic mechanism. We take every kid and make sure that we give them a shot for whooping cough. We give them a shot for measles. These viral infections may have done something in the past to help you keep from having allergy. That is, your immune system said, okay, I'm going to fight infections. And then when it comes to the point that not fighting infections anymore. The immune system looks for something else to fight, and it fights the environment. And so, but we don't have kids dying of whooping cough. We don't have kids who are blind from measles. We don't have those diseases anymore. Instead, we have allergies. So allergies are increasing. Endotoxin is something that's found in a lot of bacteria. And where there's more bacteria than anything else is probably in manure. And so if you're exposed to a lot of manure when you're young, kids that grow up on farms, kids that grow up in houses that have a large animal in the house, or in the place next to them, like in Switzerland, where your cow is downstairs and you're upstairs, they actually have less allergy. We know that there may be some influence with dietary and allergy, but not very much. A lot of studies on dietary have looked to see if you eat different things, if you feed kid different things, if you feed the pregnant mother different things, does it make a difference in the allergy? Probably the only thing that makes a difference is the breastfeeding. Children that are breastfed for their first 4 months have less allergy than those who eat a lot of other foods. Then what do we as allergists treat? We treat allergic rhinitis, which you know as hay fever. Hay fever, because the most common thing when they first started looking at allergies were people that fed animals hay and that cut the grass, and they would have allergies to the hay. Well, it turns out it's not just hay, but here we don't have much hay. Every vacant lot is full of tumbleweed instead of hay. So we have here allergy to tumbleweed and sagebrush and juniper and the desert pollens we have. And instead of calling it hay fever, we want to spread it out and call it allergic rhinitis. We take care of people who have asthma. People who have asthma are people who, when they exposed to something they're allergic to, their lung gets tight and they wheeze and they have a hard time getting their air out. They can usually breathe in, but they can't breathe out. And so you'll hear an asthma patient going like that when they try to breathe out. We take care of people who have what we call urticaria, and you call hives or whelps, where people, and this is often due to things you're allergic to. When patients come to me, the first thing I do is say, okay, what causes it? And if they can tell me, I don't need to do anything more. If you have hives every time you get around the cat, there's an easy solution to that. And occasionally we have hives that are very deep in the tissue. We have hives that cause swelling where a lip will swell up or an eye will swell closed. That's called angioedema. There's a rare form of angioedema that actually can happen internally. So your throat can swell closed and you can't breathe. You get a swelling in the abdomen, in the bowel, and the doctor thinks, oh, you have appendicitis. And he operates, and instead of finding a swollen appendix, he finds a big hive. We look at patients who have a skin rash, eczema, most often in kids, but we do see it persist into adulthood. About a third of those kids actually have a flare of their eczema with certain foods. So mom pretty soon notices, hey, when he eats a peanut butter sandwich, he gets a rash around his mouth, and his skin starts to itch, and he starts to scratch. And so we can test that child and say, yes, he's allergic to peanuts. If we take peanuts out of his diet, his eczema may get better. So we will do allergy testing to see if we can eliminate things for kids that have food allergy. We talk about food allergy as well, and again, with food allergy, the thing that's most common is somebody comes in and says, I had terrible hives, I had shrimp, and an hour later I was itching. We can test them for shrimp, but the answer is easy, no shrimp. But often people come in and they don't know what they ate. I had one patient who went to an East Indian restaurant. They were having a party, so they ate everything on the menu. And then she broke out with hives, had trouble breathing, had a severe allergy reaction. So we got everything we could think of. We get all the Indian spices, all the Indian foods, tested her with all those, and they're all negative. I said, didn't you have anything else? She says, oh yes, we had olives. Well, it turns out she was allergic to olives. So next time she wouldn't eat olives when she goes to a restaurant or a party, something she didn't normally eat. Over the years, we've developed allergies. We've developed things about drug allergy. We try to find ways to get to diagnose people to tell medicines they should avoid. I worked a lot as a research fellow on penicillin allergy, and about 10 years ago, I wrote a textbook on drug allergy with a lot of the people around the country doing the research on that to try to put it together. So we can test you and tell if you're allergic to penicillin or cephalosporin, and if it's something you should avoid in your diet. Good, welcome. We have something we call contact allergy. The most common contact allergy is something that all doctors recognize. They recognize it when they're examining a child, and they see this big rash just below the belly button. Anybody know what that is? That's because you don't wear jeans. The back of the snap-on jeans has nickel, and so we commonly see people right where that button fits, and mom has to sew a patch over that to make the rash get better. But we can test for that if there's other things that bother you. People that have nickel allergy also tell you they can't just wear the snap-on jeans. They also can't wear earrings if they're cheap. Now they can wear earrings if they're expensive, gold and silver, but they can't wear things that are cheap. And so nickel allergy does increase the cost for the boyfriend. We can test for that by putting a patch of nickel on somebody, watching it actually for a couple days. It's not the same as an allergy to a pollen or a drug or a food. It's something that takes a long time for the cells to become angry at whatever is touching them, and they get what we call contact allergy. And we do see it other things. We're starting to worry about it with the implants of joints. And so we look for other things that might cause what we call contact allergy. The other most common contact allergy is probably one here. Well, you may not have had it in Los Alamos because we're pretty dry. We don't have as much poison ivy as many other places, and that's called a contact allergen. You go out and walk through the poison ivy patch, and you're fine. A day later, you may have a rash. I remember one case years ago in Los Alamos when my kids and lots of kids in town were going over to the pools, the hot tubs, the springs over at Alamos Springs. And one day, these two boys came in, and they both had a rash right around here. It was only about that big. And I'm sure, looking at it, and we tested them, I'm sure what happened, somebody had thrown some poison ivy in that water before they got in and sat there for a while. The poison ivy allergen that causes the reaction is the oil, and it'll float on top of the water. And if you sit there for a long time, yes, that's where your contact will be. And you don't even have to touch the poison ivy. And another common allergen that we see, at least not much in New Mexico because we don't have so many insects, but we see patients who are allergic to bee stings, honeybees, wasps, and we have to test for them because most people don't know what stung them. You know, what stung you was a bee. Well, the bee may have been a wasp, it may have been a yellow jacket, may have been a hornet, and it turns out they're all different. Most people that have bad reactions only have reactions to one. So they'll tell you, I was stung by a bee and I had this horrible reaction. I couldn't breathe. I got hives all over. I almost died. But then, 2 months later, I was stung again and I didn't react at all. I guess I'm over it. Well, what happened is once you were stung by a bee, once you were stung by a yellow jacket, they're different. The bees are easy for us to diagnose because bees have barbs on their stingers. The honeybees do. And it leaves a stinger behind when it leaves and goes off and dies. And for that reason, honeybees aren't very aggressive. And most of the beekeepers will tell you they don't very often get stung. The yellow jackets, the wasps, they're different. They don't have barbs. They can sting and they can go sting again. We do have, when we see our patients with allergies, and we ask moms to watch for this, and they all can tell us about it. Most people, when they scratch their nose, they go like this. You watch an allergy patient, the kids come in and they start learning this about 3 years old. They go like this. Because what happens, it doesn't just stop the itch, but it also opens up your airway a bit more, because you're not just itching, you're also congested. So we see that. And of course, we see the kids who are having a lot of trouble with their eyes, and they get a particular grimace. I saw a little child yesterday whose mother came in and said he had this terrible thing. We kept him out of school because the white of his eye all swelled up. We call it fish eye. And what happened is he got some pollen in the eye. And the area where the pupil is doesn't swell like the white part of the eye. The scleros has more allergy reaction. It'll swell up and make a big bubble. The first, most important part of allergy to me is the history. And what I do when I have allergy patients is I ask them when they have trouble. And boy, if you live in Los Alamos and you have juniper and you have allergy in February and March, I'm pretty sure it's juniper, although occasionally I'm mistaken and the juniper turns out to be elm, which is right outside your house, because elm pollinates about the same time. If your trouble's a little later, it can be oak. That's a pretty short season. Early summer, it's our grass pollens in the years that we have enough moisture to make things green. Our grass pollen allergy here is relatively mild to most areas of the country. And then after the grass, we have what we call chenopodds. Those are your garden weeds, your tumbleweed, your kochia, your pigweed, your careless weed, the weeds that grow when you try to grow something else. and those pollinate in the early fall. They like to put out their seeds just before the frost, so those seeds will lay dormant and grow again next year, because most weeds are what we call annual plants. They die off every year. And then the patients that are having trouble now, in October, November, those are patients that are allergic to sagebrush. Sagebrush doesn't die during the winter. It quits putting out pollen when it gets covered with snow. So if a patient tells me they have allergies after the hard frost, I know it's either sagebrush or the cat in the bedroom. And of course, the juniper is the common one. You know what junipers look like between here and Santa Fe. Half our trees used to be junipers, half used to be piñons. The piñons aren't very drought resistant, so now they're mostly junipers. Most areas of the country, the most common allergen is a little bug called a mite. They're so small you can't see them with the naked eye. It takes a microscope to see them. They live in bedding. They eat things that other animals don't eat because they can put it out in their dropping and then re-eat it after digest it a little bit more. And those droppings are small enough to get down in the airway and cause asthma, to work through membranes and cause allergy, to get in the eyes and cause allergy. So the dust mites are a very common allergen. About 20 years ago, it was thought that dust mites were probably the cause of asthma. And so I was asked to do a study here as part of a national study to look at our children and see if they had asthma. And some of you may participate in that. We took all the kids in the junior high school, at the middle school now, and ran them through histories to find out who had allergies. In their biology class, they did breathing tests, and we picked out 60 kids who had asthma. We then picked out 60 kids who sat next to them that didn't have asthma as a control group. And we studied those 120 kids to see what the differences were. We went to all those houses, vacuumed 5 dust samples in every house. So we ended up with a lot of dust to look at under the microscope. And we looked for dust mites. The only dust mites we found were in kids who just moved here from someplace else. Didn't find them in the bedding of local kids, didn't find them in the carpets, didn't find them in other parts of the house. So the dust mites that we had were imported, and they died off because of our dry climate. Dust mites don't survive if humidity is less than 40%. So we don't have dust mites here. But unfortunately, we looked at it, and our incidence of asthma was the same as the other places in the country that were studied. And our kids instead were allergic to pollens. They were allergic to dogs and cats. Come in. What do we as allergists do? I've already talked about the history, which I think is the most important part. I mean, what causes you trouble? What time of year do you have trouble? Do you react when the cat's in the room? And what foods do you react to? The exam is pretty easy. We can tell a stuffy nose. We can tell an itchy eye. We can hear a wheeze. And then we end up trying to find out what it is and trying to document it before we treat it. And with that, we'll do allergy tests. Allergy tests are applying a small amount of what you're allergic to the skin to make it cause a hive, and then reading and trying to diagnose what you're allergic to. In patients who can't be tested, we can do blood tests. The allergic antibody, unfortunately, is an antibody that's bound mostly to the cells that are reactive. So often the blood tests are negative when the skin tests are positive. So our blood tests, I reserve them for patients who can't be tested. Child has too much skin disease, somebody can't get off their drugs to be tested, then we'll do blood tests. And then, of course, how do we treat allergies? You all have heard all the ads for antihistamines, Claritin and Zyrtec, and all the drugs that are now over the counter. Benadryl, been around for a long time. These drugs were developed in the early 1940s and haven't had side effects except for drowsiness, and the newer ones don't. So we have drugs that will help. We can put cortisone on things and they get better. Get a skin rash that's allergic, cortisone will help it. get a nasal allergy that's severe, and you can spray cortisone in your nose. The cortisone drugs have been safe. They're safe enough that the first one was released for over-the-counter use about 3 months ago, and we're going to see more of those coming over the counter in the next 6 months. So we'll be able to buy things like Nasacort and Flonase and Nasonex without a prescription because they're safe. And then we have decongestants, and you can buy Afrin nasal spray, or you can get Sudafed. Unfortunately, the decongestants don't last as long, or your body builds up tolerance for them. In addition, the topical ones, when you put in the nose, tend to irritate the nose, and then you get dependent on them and you can't stop them. And so I don't very often prescribe decongestants as nose sprays. And of course, the best way to treat allergy is to avoid it. I use cats because it's probably the most common thing I see that people are allergic to. I did have a fella, I hope he's not watching, but who about 2 years ago came in and said, I'm allergic to my computer. This was just after Christmas. And he says, every time I go work on the computer, my eyes itch and my nose runs. I think I'm allergic to the computer. I said, okay, let's talk a bit more about the room where the computer is. Well, it turns out that they got the daughter a hamster for Christmas. And the hamster cage was in the computer room. And hamsters and rodents like that like to mark their territory. They mark their territory by spraying out and putting a little urine in the air. The urine turns to be high in protein. And that goes on to telling about what the mouse did with hantavirus the same way, but it puts out things you can be allergic to. So we moved the hamster and he's able to work on his computer. And of course, if we do all those things and your allergies don't get better, then the next thing we do is we talk to you about taking allergy shots. Allergy shots are mixing up the stuff you're allergic to. We don't collect the pollen ourselves anymore. There's commercial companies that go out and collect it, sell it to vaccine companies, and we buy a vaccine that has some juniper or some sagebrush or some tumbleweed, and then mix it together in our office and give patients shots. By gradually increasing the dose, we can get them over their allergies. It works most of the time. There's something new on the market in the last few months, and that's putting allergies under the tongue, the allergy medicine under the tongue. Turns out it takes a very high dose. There have been some reactions to it, no deaths yet. And they've developed these primarily for things they're found in very large population areas. We don't have them here yet. It's come out for grass in May, and in the last month they released the sublingual pollen tablets that go under the tongue. They released those for ragweed. So right now we have them for grass and we have them for ragweed, two pollens that we don't have. So when people come in and say, can I use those medicines under my tongue for my allergies? I say, yes, you can if you live in Baltimore. Or if you live in Seattle where there's a lot of grass. But it's going to be a few years before they do enough research to say, okay, this is the right protein we're going to put in there for juniper. So eventually we may have something like that here. Doesn't work as quickly, takes about 2 years to get benefit, and you have to do it daily, relatively expensive. So we'll still have people that take allergy shots. Our skin testing goes back a long way. Allergy shots were first given in about 1910. and so we have done that. And this is supposed to be a women's allergy group. So I need to talk to you about what's different between women and men. Certainly, we look at women. It turns out that, I look at my patient population, I do have more asthma in women. I see more of the kids that run cross country that are female that have trouble with asthma than others. So it is more common in women. Hives, about 60% of the people who have hives are women. So we see hives more often in women. So allergy is more present in the female. The angioedema we'll get to in a minute. But that's almost the severe one is almost entirely a women's illness. And it turns out that autoimmune diseases are more common in women. Lupus we rarely see in a man. So we see the autoimmune diseases more commonly in women. There's an occasional woman who's allergic to progesterone. If you have that, you're going to be famous because you probably get published. That is, if you're allergic to progesterone, it's a woman who will have hives or maybe dropping her blood pressure at times just before her periods when the body's putting out more progesterone. And there have been a few cases, mostly written up in the literature, a few cases where a woman had to get her ovaries removed to reduce her progesterone so that she wouldn't have these reactions. So that's a rare form. I do have a few women who have had hives at time of the month for them, and we can actually take a little progesterone and skin test them with it, and they get a positive response to the progesterone. Of course, women become pregnant, and pregnancy is a problem in allergy. Some women get better during pregnancy, probably because their body makes more cortisone. Other women have more complaints because pregnancy is often associated with a stuffy nose anyway, and then it makes your allergies more apparent. Looking at asthma in pregnancy, if you treat a woman who has asthma during pregnancy, it turns out that her baby is healthier, no matter what drug you use. So all the drugs we use in pregnancy, in asthma, we're able to use during pregnancy. And many of those have all been proven to be safe, and the babies turned out to be healthier if the mother is breathing well. The most important drug for the baby is oxygen. So and then there's a rare case, I saw another report of it last week in the medical journals, where women are allergic to the male semen. They're allergic to the protein put out by the prostate, and it probably is PSA that they're allergic to. And so that during sexual intercourse, they'll have an allergy reaction. They'll break out with hives, they'll have trouble, itches, so they have an allergy reaction. And there have been one successful treatment where they gave a woman shots of the male semen or the male PSA, and she got over her allergy and was able to conceive and have babies. So that's for women's allergy. We've talked a bit about how to treat asthma, how to treat hay fever with antihistamines, with cortisone topically, with decongestants. Asthma, we have lots of drugs for asthma. We have drugs that you can take that will open up your lungs that you take as an inhaler or a nebulizer. We have pills that'll help block the reaction. We have ways to treat asthma, both whether you're male or female. And we have new injections that actually help block the asthma response. This severe episode called angioedema is found primarily in women, very rare in men. There have been severe cases with even deaths where people have their throat swollen closed with a big hive in the throat. And so it's something we're coming out with new medicines now that can treat that. It's found primarily in women, and one of the ways you can treat it is actually give the woman androgens, male hormones, and she won't have as many reactions. We know now what it is. It's an instability in the immune system where these people have complement that's excited very easily, and they get this terrible reaction where things will swell. You can give them drugs that actually reduce this, and new drugs are come on the market all the time, but they're terribly expensive. We used them once in Los Alamos, and turned out it was $19,000 a shot. So these things they're new. It's a rare disease. It takes a lot of money to develop these. I don't know if the prices will ever come down because this particular illness probably has 600 or 800 people in the United States with it. So it's not a common illness. I have a couple patients in my practice with it. And then, of course, asthma and pregnancy is something we watch and care for. And I think it's important that pregnant women be treated for asthma because it's important for their babies. Their babies are healthier if they're treated. And so I do emphasize and see women during their pregnancy to try to make sure that we keep them well during pregnancy. And with that, I'm open to questions.
I have one. I was one of those pesky patients from you long ago with all the different tests and treatments and stuff. And I have essentially don't have allergies, at least airborne stuff like I did. Is that common?
It's common if your age is under 10. That is, we see about a third of the kids. A third of the kids outgrow their allergies. Occasionally adults do, but adults for the most part don't. Somebody sees me and says, well, why me, why now, am I going to get better? I say, probably not without treatment. When I was a research fellow many years ago, we studied a large group of children with grass shots. We were working on a new way of giving grass shots to the patients, but we had a third of the patients that were taking placebo. They didn't know they were taking placebo. We didn't know they were taking placebo. And we brought them in every month and asked them questions about how's your allergies, measured their nasal flow, that sort of thing. And it turned out about a third of the kids who had allergies looked like they were getting allergy shots. They got better. And we had almost 100% of the others got better. But we saw a third get better on their own. So there is something where people can desensitize themselves, probably just like we give them with shots. They get enough of the pollen, the body starts to fight it off. But it rarely happens after you're past the age of puberty.
So does that mean I'll be on allergy shots the rest of my life?
No, allergy shots the rest of your life. We give allergy shots, and the standard is giving allergy shots for about 4 years, 3 to 5. If people are doing well, we try to stop at that time. And 80% of the people do well enough they don't have to stop. Unfortunately, about 20% of those fail. And if you're going to end up being one of those, yes, you may be on allergy shots for a long time. I do have one patient, I won't give you her name, who used to come in for allergy shots. And I said, "We got to stop your allergy shots. You're doing fine. Your shots are doing well." She said, "Well, you know, I'm 103, and this is the only time I get out. The van will bring me over for my allergy shots." We kept her on allergy shots. I'm sorry to the insurance companies. Thank you.
Thank you, Dr.